Welcome back, everyone. I hope you learned a lot in your breakout sessions. My name's Annie.
Oh, we're just getting underway. Yep.
And I'm with the unit's Island Center. I'm pleased to host our final panel at PPF20, Patient-Oriented Research and Health Technology, moderated by Interior Center patient partner Paul Burgener. Our panelists will discuss how to engage people around integrating technology into healthcare and how we can use technology to engage people in patient-oriented research. Our panelists are Beth Bourke, Fred Cameron, Dennis Hore, Christopher Horsethief, Sean Spina, and Bruce Wallace. I'll be back later to help out with the Q&A. Please remember to use the Q&A function at the bottom of your screen as the panelists are presenting. And Paul, I will pass the virtual microphone to you.
Thank you, Annie. I'm Paul Burgener, and will be your moderator for this session. I'm a patient partner and co-lead of the Interior Patient Engagement and Research Committee. I'm connecting today from Nelson in the unceded lands of the Tunaha and the ancestral lands of our panel member, Christopher. So thank you, Christopher, and all of your people. I'd like to introduce our panel team today. We have 3 presentations to provide context to our theme of engaging technology in healthcare. And then we'll have a panel discussion and answer questions you've sent in on the Q&A or in the chat. Our presenters in the order of presentation are Christopher, who provided our keynote address this morning. He's back to share his work on revitalizing culture and language and connecting communities through technology. Then Bruce, Dennis, and Fred will share their collaborative work to develop acceptable and accessible drug checking technologies. And finally, Beth and Sean, who will share their work to evaluate a pilot project that will provide hospital level care to people in their own home using a suite of healthcare technologies. We'll have about 10 to 12 minutes for each presentation and time for questions after the presentations. So if we're ready, I guess everybody, if we got people, oh, we've got lots of people here now. So let's get started. Christopher in his morning talk showed the efficiencies of a web of interactions for sharing ideas and connections, and the effect when this was disrupted and stuck in the state of having to do everything from scratch. I think our health system has evolved from a centralized structure, and as we're experiencing COVID, we are separated from large central interactions. So very similar. Technology can assist us in supporting a network which can reach people in their location. So I'll ask Christopher to share his teachings on the experience of 1,000 generations to connect with communities in their location and how that approach can work with technologies to provide care where people are who presently are not able to have access to the centralized facilities. So Christopher, can you provide your context for problem solving and using technology which will provide a more equitable idea of healthcare for us?
Yes, thank you, Paul. I kind of want to start off with just a couple of ideas, and then I want to present some pictures. We have been, in my other life, I'm a professor. I teach mostly in person, but of course this year, all of the residency programs that I teach in, where we spend part of the year together and part of the year at home, this year they're all online. So having taught using some technologically mediated course management spaces, it's given me a little bit of a jump start. A couple of years ago, we started working with the Ktunaxa Nation Council, trying to identify some strategies to cut down on travel and also trying to save a little bit of the time from a lot of the busy work with people driving when it wasn't necessarily important. So we did a feasibility study for adopting video in a more meaningful way. And of course, we tested 4 video systems. They all worked great and nobody picked them up. No one wanted to use them. And I live, a country away from everyone else. And I found myself driving the 4 hours to Cranbrook, sometimes for meetings that would be canceled, and then driving myself home. So when we started to think about what was happening with some of the challenges to healthcare and in-person meetings this year, we were a little bit ahead of the curve in being able to remind people that the nation has already started to look at some viable alternatives. And by the time I was looped into the conversation, we had already started using Zoom and WebEx pretty significantly. At the very first meeting that we were able to have with some of the senior leadership from the Nation Council, there was a concerted effort to work with WebEx and try and figure out how we could get everybody working together when we were under these conditions where we couldn't necessarily be as close to people as we were used to. So I am going to share my screen, and I want to just provide a little bit of an example of how we were able to do this. This was very early in work with the Traditional Knowledge and Language Program. You can see, of course, we've always got a dog in the picture somewhere. So Samantha Sam, who is our support worker from the Kiskunok First Nation, is in here. You'll also notice Sophie from our Chatzchanach panel today. And then we have a couple of our elder women at the bottom. The thing that I wanted to mention about this, every one of these pictures is a different one of our reserves, a different community, all the way from Spokane to Tobacco Plains, to nearly to Radium. So that's quite a significant area. And there were two other panels here, and when we started to swipe through them, we realized that there's nothing that stops our community members from Vancouver, or our community members that live in Missoula, or our community members that live in Jacksonville, Florida, from being more of a successful part of our research. Many of our Ktunaxa academics from both our American and Canadian communities, they are a prime case study for the brain drain. Most of them go to graduate school. They're not given the kind of competitive jobs to stay at home, and many of them move away. But now we're finding a way to bring people back into these kinds of conversations. This particular meeting was a discussion of how our community has always been able to protect parts of our culture under duress. And of course, we started by talking about the residential school. We talked quite a lot about the Indian child welfare mechanism, the 60s scoops, forced adoption, those kinds of issues. And we started to look at some of our strengths. How is it that our community was very easily able to look at our Bitterroot dig this year, and how did we make sure that we didn't lose it? Our Bitterroot chief basically called everyone and said, it's got to be small family dyads. It's got to be small groups. Don't go alone, but don't go with people you don't live with. She made sure that she told everybody which particular area to go to where the Bitterroot was ready at that particular time. She was able to share that information and get people going about it, at the same time saying, I know this is different. I know this is a little bit stressful and this isn't what we're used to doing, but we've always been really good about protecting parts of our culture that we knew were important. A process sometimes in my work I refer to as de-differentiation, where you have to use some of those survival strategies that you would otherwise not consider. And don't have a big feast with 1,000 people. Don't bring 200 people together. Don't get all the kids from the school and all those families interacting with all of the elders. This year we're going to do it differently, but we're not going to let it go. We're going to make sure that we're doing these things. So this is a part of the discussion. We had actually thought about applying for a grant to document. There were about 13 ways people were talking about parts of the culture going underground or going into a social distancing phase. And unfortunately, the only thing that would have been helpful about the grant were honoraria for people's time. And that was the one thing we couldn't spend it on. So that was really disappointing that we did not move forward there. But we were able to continue our work on health research by not only bringing our community members together and our elders from both countries, from several provinces, and many people from Washington State, but we were also here. You can see that there's members of our interior health team that are joining us here as well. Bernie is up there, Alex is up there. Santa was not able to be on this particular call, but this was just the next phase for conversations. There are a few really specific problems that we ran into. We discussed this in our most recent team meeting here. And I did want to just show this if people haven't seen it. These are our watch parties from today, because we wanted our elders. Marie Nicholas is off to the side there in the red coat. She wears her red coat and everything. And then also, this is at the Ktunaxa Nation Governance Building, where our letter of understanding with Interior Health was signed, where we do most of our work with their leadership. And we were able to get 6 or 7 of the elders together, set them apart, give them their own tables. Everybody had their temperature taken. Everybody made sure that everything was wiped down. They were able to join us there. And then also here, this is my favorite picture. These 2 ladies are always together on their video conferences because they're sisters. They live together. And when you look at them in these video conference scenes, it's pretty common that you see just the tops of their heads. Or there's 2 of them and you just see a part of one face and a part of the other. They've found ways to take fairly limited technology or access and find a way to not be challenged or scared off or turned off by that. So with that, I did want to mention just a few of the specific problems that we're still working on, because even if we were to find out that we went to a better phase a month from now, and everybody said, in November, we're going to get back to work in the office, our elders still wouldn't do that. We've told the Nation Councils informed people that work, including the elders, should not resume until after winter, likely until March, because they are the most vulnerable population. So even if everyone got back in the office next week, we're still working on making sure that they are connected. And the primary issues that we were having is that some of our elders either don't have computers or don't have, even if they have a phone, they don't have a strong enough connection to carry video. So quite often in these, you will just see a phone number that pops up and they don't ever get to join us by video, which puts them at a little bit of a disadvantage. Recently, we were reviewing 3 pieces of artwork that our team, we had a call for artists and we wanted to pick a community artist to kind of display some of these ideas. And a couple of them were at a bit of a disadvantage because they weren't able to see it. Another really common problem are connection issues with respect to device. So at the Nation Council Governance Gym, it took them about a half an hour before they got even one of the laptops that was there to be connected. And then it still took a while for them to be able to hear it. They actually had to listen from one phone that went into the PA system. So there are those kinds of quirky, glitchy problems that we run into. Another problem is when we get a Zoom invite and we try and log in and it tells us that Zoom's not installed, even though we've used Zoom every day for the last 3 or 4 months. That kind of tends to have some of our elders panic a little bit, because then they try and go through the process really quickly. And then the other issue is some of our community members, because of where they are, their connection, their operating systems, some of them can only use WebEx. They can't get Zoom to work. And some of them can only get Zoom to work and they can't get WebEx to work. So we have had a few problems trying to figure out what exactly is that matrix and what is the problem? What is it that's missing out on there? Our diagnostic problem solving is not as great as hopefully it might be, because we haven't figured that out yet. But what I can say is there is this propensity, there's this willingness of our community, including our elders, to be engaged with technology in the way they never have been before. The problem is, once in a while, when it comes to the actual actions of doing it, we have to be very patient. We have to understand that sometimes there are hearing issues, sometimes there are sight or vision issues, and the best strategy that we've found so far is for one technician from each of our communities to make a common space in a health building available for 2 or 3 people, as long as they're meeting the social distancing requirements. But the added benefit is they are also generally participating with a nurse or somebody that is very knowledgeable about social distancing and COVID concerns. So nothing is really slowing us down other than trying to make sure people are connected. and when they disappear in a meeting, trying to make sure that we get them back. But we are still having them interact with their peer groups, the people that they feel lonely or the people they're missing, their children, and most importantly, with respect to this conference, the health researchers that they've been working with for several years now. So those are just a few of the pictures that I wanted to show, really trying to drive technology, really trying to make sure that it's there, always working on it. I think by the end of the pandemic, hopefully we'll have it figured out.
Well, very good. Thank you very much. And yeah, I had troubles just before coming in here. My microphone wasn't working right. So even with, I've got a 100 megabit fiber feed to my computer and it still doesn't function. So it's a big challenge when we are often looking at things from an urban perspective, and where software developers happen to be, they aren't necessarily in the same field conditions that a huge population lives in. So thank you. Well, now we'll move on to Bruce and Dennis and Fred, and they'll share their collaborative work to develop acceptable methods there for drug checking. Okay, move ahead.
Thanks. Thanks, Paul. This is Bruce Wallace with the UVic School of Social Work and the Canadian Institute of Substance Use Research. I'm going to start us off, and then Dennis Hore will introduce himself from UVic Chemistry and Computer Science, and then Fred Cameron from Solid Outreach. Next slide. So first, want to acknowledge the territory that we are in Victoria, which is on the traditional territory of the Lekwungen people of the Songhees, Esquimalt, and Saanich nations. And at this conference and for this discussion today, I think just really recognizing the ongoing role that research has had in colonization, and also for our presentation specifically with drug laws and colonization. Next slide. So we're going to talk today about the Vancouver Island Drug Checking Project. And so this is being developed. It was funded from Health Canada and Vancouver Foundations and others to help us get initiated. And basically, it was initiated as a project in response to the overdose crisis in British Columbia. And we released it as a form of collaboration between social work and chemistry and harm reduction groups and drug user movement as a way to try to move things forward. So it's a multi-year project to pilot and evaluate drug checking in community settings. So in this way, it's research with piloting at the same time, this combination of being able to actually provide a service while also having research evaluation. It's focused on assessing the limitations and benefits of the instruments, of the technology, as a overdose response, and to work with the technology partners to improve the functionality of those instruments, and then also to inform the scale up of drug checking. And so basically it has this dual sort of role of trying to first advance the technology role and the instruments role, which in harm reduction, and then work with the harm reduction side to be able to get technology more integrated. Over to you, Dennis. I think Dennis might have had some connection issues here. See if he logs back in, maybe. Yeah, he just sent a text saying he's trying to reconnect now.
And you're in an urban location, are you?
So-called, yes. Fred, I don't know if you want to jump ahead or if you want to wait and we'll just follow in order. You're mute.
Yes, that would work just fine.
I'll start my intro to you then.
Sure.
Okay. So we'll do the technology introduction to the technology after with Dennis. And so basically, once we had the instruments ready to go, we took them to Solid as the drug user organization in Victoria, and also the organization that's been have an ongoing role as a patient partner in research with UVic and the Canadian Institute for Substance Use Research. And thanks to all the support from BC Support, the Vancouver Island unit, to continue all of our work together. And so we started with a show and tell, basically. We had all the spectrometers, and everybody was keen to see what the shiny instruments would look like. That's the new part. Everybody knows sort of some of the other harm reduction parts, and that was the exciting thing to sort of gather. So got some pizza, went in the basement of Solid, and started with the, basically did a show and tell about it. And people were able to have that knowledge exchange of just sort of turning them on and seeing what worked. So we started with that. And then we did once we were ready to start the service, we did a soft launch in Solid. So not promoting it anywhere. Nobody knew we were really starting. We just started with Solid so that all of our mistakes would be with Solid. And we didn't want anyone else to watch. And so we did it there. And then we developed it, and now we're operating at 5 days a week in a couple of sites in Victoria. And so maybe move over to you, Fred, on some of what it was like on your side of all those mistakes.
Yeah. So yeah, I'm Fred Cameron, operations manager with Solid, and I'm a member of the Patient Advisory Council. So we were involved right from the beginning in the development phase. We started out in the basement at our old office. It was just an idea at that point. So we had, initially, I think there were probably, just our membership accessing the service, but the goal was much bigger than that. Of course, we're the local drug users union, so we work in the safe consumption sites and providing harm reduction gear around town. So we're, directly related to a lot of the people who are in the community. So from our end of things, we're seeing it as a community problem, and we're bringing in samples and recruiting participants for the project. So a lot of the things that came out of this, working in the safe consumption site, for example, we have access to the paramedics and the drugs that are causing overdoses. So we were, targeting the problems right away. We had a number of things that we were looking to solve. But another one was just giving people accurate information about what the marketplace was like. So they were able to go out and find drugs that they knew were safer. Safe is never the right word in this area. We're dealing with fentanyl for the most part. But the instruments were good for just about any kind of hard drug or anything that was pure. So, we had parents coming in to make sure that their kids were partying responsibly on the weekend. Again, our own membership, that's my key piece. We have about 40 or 50 people, and their livelihood is first and foremost to me, making sure that they're safe and healthy. So it's been absolutely just a wonderful project to be a part of. It has also put us in touch with service providers from around town, and our whole network is stronger as a result. So, not sure what I missed, Bruce, if you want to chime in here.
I think one of the challenges that we had, I think one of the real benefits, as Fred said, is that we weren't coming into community to research a problem. Like, we were coming in with new technology to be able to actually integrate that technology into the work with Solid as an overdose response. But one of the challenges with that is that the technologies that we were working with, as I said at the beginning when we had the slide, was that they were in development. These are technologies that typically have not been used for harm reduction before, and that's what we were trying to do. So we were going through those growing pains. And I think one of the challenges is that when we introduce technology and patient-oriented research, is that those growing pains might be expected on the research side, but they have impacts on the community side. And so Solid was often depending on one of our instruments and really wanting the results from one of the more sophisticated instruments that could give some of the more detailed results about drug composition. And it was probably the hardest one to continue to be operating in a really reliable way every single shift. And so there's just that tension, I think, of when we do patient-oriented research with technology, that how do we make sure that we're engaging in community also in a way that where people can depend on us, even though we know that it's going to be, that we're doing research questions, we still don't know how it's going to fully operate. The other part I think that really we learned from Solid was that Solid had a very different idea of how the service would run than how we thought it would when we wrote it into a proposal for funding. And so in our proposal for funding, we were very thinking that most likely the person sitting in front of us would be the person who would most likely consume the substance that they were getting checked. And Solid was able to develop a very much a broader model that was much more based on peer networking and being able to access samples through buildings and through other people in the ways that when we had to modify to say, like, how can we provide results better to people, knowing that they might be going out broader than just the person in front of us. So, so it was interesting to see how that changed.
One of the biggest things for us was, moving around from site to site. Usually people would want to get the results within 20 minutes, otherwise they're going to consume the substance anyway. So unless we were going through the marketplace, as I had suggested earlier, it was very difficult. We can't get a hold of the people because they don't have phones. So having boots on the ground with our outreach team, that gave us the ability to get in touch with people down the line. Because it's not an easy group to communicate with. Most don't have access to computers. A lot of the time they've lost their phone or they don't have the ability to charge it. And we're talking about a dual health crisis, really. We're dealing with the COVID pandemic now. That's moved people into different housing sites around town. It's just been both difficult and exciting time to be a part of something like this. Yeah.
Okay, well, thank you, Bruce and Fred and Dennis, wherever he is. We'll move along and maybe he'll come back and be able to describe to us mass spectrometers and Fourier transform infrared spectrometers and all those wonderful things. But so we move now to Beth and Sean and hear about their hospital from home.
Fantastic. Thank you very much, Paul. Really appreciate the introduction and hearing about all the innovative ideas that are happening here. Beth is a patient partner that I got to work with through the last 15 months or so. And the project that we're working on together is, it's called Hospital at Home, which is a very innovative care model. It enables hospital level care to be provided from the comfort of patients' own homes. And basically, it's provided through a variety of different systems. We can have in-person virtual visits, and the patients receive safe, effective care from various healthcare providers throughout the system. And all of us who are caring for the patients are experienced in acute care hospital medicine. And despite the patients being at home, they're still admitted to the hospital, and they remain under the care of the hospital team. And as you can appreciate, if we're going to take acute care and deliver it in the patient's own home for a subset of patients, we are going to need to ensure that we're monitoring them in a timely fashion and in ways that we can be notified if something is trending in the wrong direction. So about 15 months ago or so, we started this journey together, and we thought that there had to be a better way of delivering care. And anybody who's worked in or been through the hospitals will know that we're across this entire province and country. Our emergency rooms are always overloaded, overburdened. Patients are in hallways, long waits, and we can't just keep building hospitals throughout the country. It's too expensive. And to tell you the truth, a lot of patients actually would prefer to be cared for at home if they could be. This model of care has been used in Australia, Ireland, New Zealand for 20 plus years, and it's never really taken off in Canada. So we started the idea last year. Two hospitalists, Dr. Elizabeth Krishy and Dr. Shauna Tierney, started off, and I connected with them last August. And it was shortly after that, as we started talking about how we were going to deliver this care, that I connected with Beth and Lisa through my research program, which is called the At-Home Research Program, and it's the alternatives to traditional hospital care offered in monitored environments. And it was very, very important to us to involve patient partners and have them contribute to the system. And it's in the development of the technologies, because at the end of the day, it's the patients and their family caregivers who are at home that have to use this. And we as a care team recognize that there's great value of having them involved with us as we go through this. So the hospital care team will actually include physicians, nurses, and pharmacists who are all very experienced in hospital medicine. They will be making house calls to these patients. This is not a chronic disease state monitoring program. This is actually acute care medicine offered to patients in their home, with an average length of stay estimated about 5 to 7 days. And they'll receive a bunch of tests that you would expect to receive in the hospital. These tests will be IV intravenous medications they can receive, supplemental oxygen, vital sign monitoring. They'll also get lab work done in their home. And patients will also remain registered within the hospital system, and we can return them to the hospital if needed. There's a significant amount of technology that's gone into this entire program. And some of it, I'm going to demonstrate here in a few minutes with Beth. But some of the technology includes some of the home health monitoring technologies, where we will be giving patients portable blood pressure monitor. I don't know if you can see it. There'll be actually, I'm just going to remove my my virtual background so that people can see this better. There will be a thermometer that they can use that connects virtually to the system, a pulse oximeter, which I'll go through in a second, and blood pressure scale and our blood pressure monitor. And there's also a scale on the floor here that probably won't use today. But one of the key things that we went through is a virtual call bell. So working with me and our at-home research program was Beth and Lisa, and they highlighted early on, and maybe I'll let you talk, Beth, about the virtual call bell and your guys' thoughts on that.
Sure. Thank you, Sean. And it's nice to be joining you from Victoria. As Sean said, I'm a patient partner. I initially, many years ago, worked for Island Health, and then recently had the experience of coming in through Emerge for emergency surgery. So wear two hats. And so with that recent experience of having been in hospital, knowing how important it was to be able to get hold of the nurse when I was in pain or whatever was going on, we said, when you're in the home, you want to have the same kind of care or better care than what you would get if you were in a brick and mortar hospital. And so being able to quickly contact the nurse without having to look up the phone number, try and dial them, get a busy signal or whatever it is, you had to be able to just push this button and get hold of your healthcare provider that was caring for you at that time. So we're still working on a little bit of it, but it's sounding like it's going to come to fruition. Sean didn't mention, but alluded to the fact that we haven't actually started this yet. We've got a couple more weeks before we go live, so it's giving us a few weeks to work out some of those bugs and be able to test not only the call bell system, but all the other kinds of technology that we're going to need to provide that care in the home.
Thanks, Beth. So we're launching the system at Victoria General Hospital. Right now it's scheduled probably the first week of November. We'll start the launch. It became a priority for the government, BC government, through COVID, and we've basically, it's a number 1 priority here, or a top 3 priority for the health authority to move forward for this. I do want to do a quick demonstration here. So one of the Beth would usually have this in her home, but just due to COVID and traveling and passing stuff around without the formality of the process, I have it here. So there's a tablet that the patients will receive, and they come into the emergency room. If we deem that they're appropriate for the program, they'll actually receive some technology and send them home. So there's a tablet that they'll receive, and I'll play this for you, and we'll go through the system. So
how are you feeling today?
It asks how the patient's feeling. We have it programmed for the hospital at home, so I'm feeling really good today.
Really good.
So I'll click really good.
Do not smoke or drink caffeine. 30 minutes. It is time to take your blood pressure. Are you sure you want to measure your oxygen by first warming up your hands and fingers and then placing the oximeter on your index finger?
So it tells the patient what to actually do as they goes through. I skipped the blood pressure one because it takes too long, but you can put it tells you what to do, and it tells them if they're doing things wrong as well. So we put the pulse ox on their finger, and then it says over here on the computer that they're waiting for the sensor, and it's reading it from the sensor. And you can see on there that I'm satting 99%, which is good, and my heart rate's
Your pulse is 71 beats per minute. Your SPO2 is 99%.
So I'm 99%, and my pulse is a little higher than usual. I'm a little nervous presenting. And then as soon as you hit continue,
It is time to measure your weight.
it actually
Weigh yourself by
sends
following
it.
these steps. 1. Are you sure you want?
I'm not going to go through it all, but it keeps asking me a bunch of things as it goes through, including your temperature, the blood pressure, and your scale. And at the very end, you push a button. It all goes Bluetooth into the computer. It actually sends it wirelessly to the hospital, and the care team is notified if there's any abnormalities, and we can see it in the hospital. We have pre-scheduled visits that we go to see the patients as well. And in advance, if something goes awry, we can actually ask the patients to individually, say we just want a temperature, we can actually ask them to take their temperature. It'll send it directly to us so they don't have to type it in. With that said, you can see that having patient partners is essential, and our patient partners have been involved with our steering committee as we've led this project. Beth has been in so many meetings, and her insight and bringing this to life has been incredible. We wouldn't have a call bell if it wasn't for Beth and Lisa, because it wasn't on the radar. So I just wanted to highlight a couple little challenges with involving patient partners in technology and bringing it to life is, I think patient partners need to be paid for their time, and sometimes in the public funding system, we're unable to pay the patient partners for their time, which is a real challenge. And we need to make a space for them in the healthcare system so that they have a voice. And because quite often it's challenging to bring patient partners into these formal healthcare settings. It can be intimidating. And I think we need to welcome them, because there's a wealth of information. Even though all of us think that we're patients, we're truly not if we haven't spent time on the other side of the counter. So with that, I just want to say that along that same vein, we are seeking input from patients, families, and healthcare workers as we develop this program that is going to expand across the province through the winter months here. And we want to know what's important to people as we build this model and what indicators of success are. This is a publicly funded healthcare system, and we need to be sure that what we're doing is actually a success, and we can make sure that we can measure the positive impact that this is having. We have if you Google Island Health Hospital at Home, there's a survey open to all public across the province to fill in and provide their input as to what they think this model should look like.
Very good, thank you. We have a series of questions that your hospital has raised here. One of them that looks fairly simple to answer is, can you use different languages on your system, which would be useful to know?
Yeah, so that's a barrier right now. The system is actually just being developed as we speak, but we have that on our radar, and we recognize and we have discussed the importance of that. But it's at this point, it's English only.
Okay. And then they've got some questions here on patients being selected. Is that done by the hospital, or can a patient say, I would like to do a hospital at home? As it progresses, I guess initially it would probably be the hospital identifying people. But
Go ahead, Beth.
There will be two groups because it is a research project. So we have some clear criteria of which patients would be eligible. And then the patient themselves would get to say, yes, I'm willing to be part of this project. And yes, I want to do it. Or at this point, no, I don't. If they do decide they are going to participate and they get home and then they say, you know, I'm just not feeling this, I want to be in the brick and mortar hospital, then they can withdraw from that being at home in their own home, and they would still continue to get the exact same care. So it doesn't mean that they get any less care. Some of the criteria initially is fairly detailed so that it can be successful. One of the things is that they live within a radius of 16 miles for driving so that the healthcare provider can get there quickly. And of course, that's really helpful if for some reason the technology doesn't work. We know that the nurse can actually get there and see the patient in person.
some of the equipment that you showed us there, Sean, looked to be relatively simple, and you had the explanation on it. Is that something such as Christopher, with some of his communities that are away from a hospital, would be able to train a local person there at one of their offices to oversee things and report back to a more distant hospital than you're looking at 16 kilometers?
Yeah. So we've purposely tried to make it as simple as possible. Plus you have to recognize these are acutely ill patients, so they're not in a position when they first come into the emergency room to take in a lot of information. So we wanted to make it very simple. We plan on teaching the patient when they're in the hospital, if you will, and then they will take the whole package home. And we've also, the computer is cellular enabled, so you don't have to go home and try to hook it up to your Wi-Fi and deal with passwords and all that sort of stuff. It actually will work in the emergency room. We'll set everything up for them while they're here and send them home, and it actually walks them through. And we also are setting up a little video that'll be about a 2-minute video that they can watch as well, that will be on the system as well. The one thing we've recognized is as this program rolls out across BC, and we're partnering with Northern Health right now, is we have a group of physicians here which are hospitalist-based. Some of the other communities in the province don't have hospitalist-based, it's GP-based communities. So every community is going to have to develop it for their own specific needs in their community. We recognize that some of this technology may not have Wi-Fi or cellular access, and we may have to adjust the program in those areas to have nurses spend more time, or maybe the criteria for who can actually be in that program will be different in those areas because they don't have the cellular capabilities, for example.
The other thing to mention is that the patient won't be by themselves at home. Another criteria is they have to have a caregiver that's there that can actually provide care, or back up, making meals, not just ordering in pizza and stuff like that, so that they're not by themselves. And then we're going to have a brochure that is in very clear lay people's terms, so that the patient and caregiver has that as well, because we know that the patient won't remember 95% of what they're told. They are acute. And so we want to make sure that they have something to refer back to, in addition to whatever the care the patient's caregiver is saying, as well as the healthcare provider is telling them.
And on that note, Paul, one of the big things we're going to be evaluating through this whole process is the patient experience, caregiver experience, and clinician experience. And we will be adjusting the program as we move forward and have a lessons learned roadmap that we'll be publishing at the end of this as well.
Well, Christopher, in your experience, does that fit with some of your communities there, or they're too distant for these sorts of concepts, or there's a different patient input that's required as a next step?
So what I would say is we do have people in every reserve community that do play a role in home care. And so it might be, I mean, it would be a little bit different and not necessarily one set of gear for one person, but we do have people that do home visits for people. And so that way you may be getting the same services while maybe at the same time, because diabetes is such high, so high in our communities, maybe also with when they come around monthly and do the diabetic foot care and that kind of thing. So then now they've got a more comprehensive list. So something like that I think would be really good. I would also, there was a little hesitation from some of our community members with some of the sensors and kinds of things that we wanted them to wear. So we were thinking a little bit even about how to bridge to wearable tech or some things that people don't put down. I call my grandmother and I'd ask her, do you have your so-and-so? And she'd say, yeah. And I knew she didn't. And when I'd say, Grandma, are you sure? She'd say, no, I don't remember where I put it down. Right. So those kinds of things as well for some of those. But I see a lot of potential applications, especially maybe where it is rural and you have somebody going around and working with several people, in a week or per time period.
And no, I agree with you fully, Christopher. And the reason we're starting off in a city, if you will, is we want to make sure this is safe. The two physicians and the leadership here, we want to make sure this is rolled out safely. And so we're being a little cautious out of the gate to make sure things are safe. But as we get it established and the workflow is established, we think we can roll out into some of these other areas if we understand what the needs are of those areas first.
A question for Bruce and for Sean, really, that when you're doing this type of research, is there funding for the implementation, or is that very difficult to access?
Go ahead, Bruce.
Yeah, we had funding for implementation for sure, and funding that went to some of the groups that, like the sites that we were working with. For sure, technology is a major expense, so quite a bit of the budget goes to the actual technology, but we have the implementation, and then we also have the research and evaluation to go with it.
And we got some funding. We got some grants from the BC Support Unit. It's been incredible. It's allowed us to do the full engagement platform and ensuring that the public is engaged as we implement this model of care. We're still looking for funding to do the full evaluation. We've been applying in a few places and waiting for the check to get mailed, so to speak.
Paul, we do have a few questions,
Yep.
a few more details on hospital at home. People are curious if you could give some examples of the kind of conditions that can be treated and how and whether that's the same or different than home care nursing, or if it's an expansion, and whether you can see the patients on video if need be at any point.
So I can address those. First of all, the video is the video, we're going to link in a video link onto the tablet here. So the patients will have our Island Health video link, my virtual visit, put in there. We're literally working on this stuff right now. So it'll be ready for go live, but so we can do a combination of in-person visits as well as video visits as required. It was important for us to make sure that we could see the patients as well as talking to them, because you can get a lot of nonverbals just by looking at them. As far as I think your question, Annie, was about the criteria for the conditions. Is that what it was?
Yeah, what some example conditions that people could be treated for at home rather than in the hospital?
So we have some clear exclusion criteria. We wanted to make this all comers can be in our program as long as they're an adult, if you will. They don't have acute pain crises. They have a diagnosis, a known diagnosis. They're medically stable but ill, and they don't have any acute psychiatric conditions. In other words, we don't have specific medical conditions that are inclusion criteria. It's more of, we want to make sure that they don't have a few things, and so that they can receive safe, effective care in the model.
So how are we doing there? Well, we still have about 7 minutes to, are there any more questions people have out there? There's Christopher has one.
I was just going to say, for Bruce and Sean, when you get to the point where you're looking for funding and research partners, I think this is the kind of thing that my community would be really interested in. One of the earliest projects or discussions we had with Interior Health was regarding ambulance service and some of the problems. They were talking and putting together a patient portal for people to identify the types of things that they wanted to contribute to as far as research participants. And this is the kind of thing that I think our community has warmed up to with the technology. So when you get to that point and you're looking for people, we may be interested in jumping in, and for your whole team, when you get to that, like, writing research proposals and looking for funds, I think we would likely find a way to try and jump in and support that if we could get in on it. We are all the way over. We're definitely more than 16 kilometers out, but I think that's something that we would be interested in.
Thanks, Christopher. And I think that's a good spot maybe for Beth to comment on the challenges that you faced a little bit with. It's one thing when we're in a healthcare system, we have access to everything, but when we're trying to partner with patients and ask them to collaborate with patients, there are challenges. I'll let you speak to that, Beth.
And Christopher, some of it goes back to what you were talking about with the technological challenges, either people not being that comfortable with the computers or not having access to them. And so I think those are some learnings that we can share at conferences like this, and the dialogues that we have. For me, trying to access the Island Health SharePoint, something that seemed relatively simple, I could access it, but I couldn't open any of the documents. So I had to download them and do a workaround. So, depending on how stubborn your patient partner is, they may give up sooner than I did. And, talking about whether people use Zoom or some other medium, people were making assumptions that we all used Zoom for the meetings, so I didn't have to use my home phone. Well, some of the meeting coordinators, no, it was just a dial-in. So up front, it's helpful to have some real clear understandings of roles, expectations, how we're going to do things, what's even available, so that people can actually feel like they are equal and they're not just that token checkbox. Oh, good, we've got a patient, or we've got someone from the community, or we've got someone from rural. Like, we really need to all be collaborating and be partners and equal partners. So that was one of the issues. Certainly COVID has increased the importance for our program and the visibility of it. And I think having to do different ways of virtually meeting or having assessments, COVID proved that we could do it and we had to do it. And so for the hospital at home, it wasn't a case of, well, gee, is there a way to do it? We've shown that we can. So we take some of those adversities and flip it around and say, how are we going to learn? How are we going to make it better and work together?
Thank you, Beth. Paul, I see there's a few questions in here about some of the technology, smartwatches.
Yeah. So can you use a smartwatch? It seemed to have a lot of the features you just showed us.
One of the big things from a public use, yes, you can use smartwatches, but from a healthcare and data integrity piece and the security of data, there's a lot of concern and scrutiny that goes into the process. We are using the smartwatches, and we're going to be putting in a secure messaging system on mobile phones for our clinicians who are traveling around. And I just did a research project on that. It just got published last week, and we will be utilizing smartwatches so that you can actually be messaged in real time on that. But as far as the biometric piece, we're not going to be using them at this point in time. And there's another question about, can we compensate our patient partners? I'll let you speak to that, Beth, but on the research side, yes, I definitely always put a budget line, and I work with a few people on this call to make sure we have a budget. And I think, like Beth said, we are equals. She should be paid for her time just as much as I'm paid for what I do. But at the health authority level, it's different.
It is, and I'm not sure why I'm going to make an assumption that it's because we haven't used or had patient partners as much in the past in healthcare, and so it's just not been thought of, but it does subconsciously put you at a different level. The other thing, even if it's not a financial, because it's really not about the finances, it's about feeling valued and feeling that you have something to say that is going to be heard and listened to. So as Fred and Bruce, you were talking about, being there, walking with the people, and Christopher, the same thing, you're actually there with the people. If I was one of the people you were walking with, I would feel that you were listening to me. And I think that's what a lot of it comes down to. It's also, I think, harder if you've got a group of professionals all working together and you have one patient partner. You look at things from the collective, and so that one lone voice sometimes is harder to be heard. So having more patient partners working on the same project is probably helpful. And I think that's what I heard Christopher, you talking about, and Fred and Bruce. So kudos to you folks for how you're doing it as well.
Yeah, comment on, the patient involvement side of things that, for the researcher people that are out there, as I'd mentioned, I'm not a medical person. I'm a industrial technology. Spent a lot of time with university research projects and industrial projects. So I was at a meeting where there were various doctors wondering, what about these patient involvement there as to how does it really help us in our clinical practice? And I was able to say, well, you are experts in the healthcare side of things, but you're struggling with your model on how do you survive as a standalone clinic with all the costs that are involved. Well, I'm a certified management consultant. It's my business industrially to tell people, here's how you run a business. I've been involved in lots of technology startups. So, even on some of the stuff we've talked about today, I understand what you're talking about because I've designed spectrometers. I've dealt with mining situations where we had to send data for daily maps of their drilling programs over radio telephones and things like that. So that type of shared experience brings in a wider scope of disciplines, not to tell people how to do the medical side, but to really say, what is it that is bothering you in trying to move things ahead? Maybe I can help. And, it's not about being a medical subject. We certainly need people that are part of the testing, but there's a lot of auxiliary services that I think also come in when you expand the multidisciplinary sorts of side of things. So that's a little pitch for patient involvement in the research. I think
it's the life.
Out of time now.
I was just going to say, Paul, I agree. It's the life experiences that the other partners have had that they can share to make the program that much better and richer.
Well, thank you all. I guess back to Annie there. We're about at time, are we not?
Yes, we're just at time. Thank you, Paul, for your excellent moderation, and to all of our panelists for their thoughts and contributions. I think we are now going to join another room for closing remarks from Elder Roberta and Dee Taylor. So we will see you there.